We present the freehand ultrasound guiding puncture technique for PCNL. We will first describe the technique in brief and then show the ultrasound recordings, which are almost unedited, in 2 patients. The first patient has an inferior calaceal calculus. An open-ended ureteric catheter has been passed. The pelvic calaceal system is opacified. The needle is oriented on the patient in the axis of the calyx and the stone. The lateral border of the erector spinae and the 12th rib are marked. The ultrasound probe, which is an abdominal convex probe, is placed along the line of the needle and the kidney is scanned. The kidney is scanned in its long axis and the desired inferior calyx is located. The needle is advanced, keeping it in line of the ultrasound probe firing, in which case it will be seen as an echogenic white line. Sterile saline and not ultrasound jelly is used for the probe. The dotted line is the puncture guide line. The needle will be seen at the upper right hand corner of the screen. The needle is gradually advanced up to the renal capsule under vision. As the needle traverses the hypoechoic dark cortex, it is seen very clearly. The needle is thus advanced into the calyx and the clear flow of methylene blue stained fluid is shown. The needle entry is correlated on the C-arm image. After tract dilatation, a glimpse of the stone is shown. In the second case, we show a patient with a pelvic-ureteric junction stone with a dilated pelvis and dilated calyces. The CT scan image is shown. With a similar orientation as earlier, the needle is positioned in line with the ultrasound probe. The movement and the line of the needle is seen as it advances in the parietes. Have not used ventilatory apnea during the puncture. Apnea at the time of the puncture is helpful. Machine we use is an Aloka 3500 SSD with an abdominal convex probe UST 9123. In the first pass of the needle, the calyx and the direction of the needle are not aligned. The needle is withdrawn, aligned with the desired calyx, and then re-advanced under vision. The probe has a length of 9 cm and a width of 3.5 cm. The needle entry with the probe makes a 75-degree angle with the skin surface. We have briefly demonstrated the probe with its puncture guide and the needle entry along the puncture guide line for comparison. The freehand technique is more versatile than the puncture guide technique. As the skin entry point can be varied, more lateral punctures are possible. Non-filling calyces and stone-filled calyces are difficult punctures. Mobile kidneys, a stiff renal capsule, and a blunt needle can result in difficult punctures. Echogenic cortex can also make the puncture difficult. If the calyx is not properly visualized, then a modification is used. In the modification, a composite technique is used. The needle is advanced up to the capsule using ultrasound. In conclusion, freehand ultrasound punctures are versatile and performer dependent. They result in lateral punctures. A good knowledge of ultrasound scanning is necessary.